Hello, we are hitting cancer below the belt, and we welcome you to our FightRight podcast. Our FightRight podcasts are recordings of holistic medical practitioners and healthcare practitioners to help you create a bodily environment where cancer is challenged to survive. Today, we are very fortunate to welcome back one of our favorite presenters, Dr. Christian Jenski, who actually serves on our advisory council, as well as being a really close dear friend. Dr. Christian Jenski is a board-certified functional medicine specialist. And today, Dr. Jenski, first of all, welcome back.
Thank you for having me.
Yeah. Today, we're actually going to be talking about a subject that I don't think that most Americans really consider to be too much of an issue. And we're a cancer prevention organization. We're starting to see this as a potential issue in the literature and in the research that comes across our desk. And so we knew exactly who to contact, and that was you, to help us explain this. Do you know, I think it's 4 or 5, but I'm not sure. Do you know how many medications the typical American is on these days? I think it's about 4 or 5. I'm not sure.
I would say probably at least that, probably closer to 5, yeah.
Wow. Okay. So that's what we're talking about today, is these common medications. They leave potential deficiencies in the body, not even to mention all the side effects that they obviously are giving these patients. So let's talk about some big ones. I know we've talked, me and you privately, about statins. A lot of people are on statins. What is a statin? And tell us, why it actually benefits the body.
Sure. Okay. So just to start, I would like to say overall that, what Mindy said is absolutely true. And the goal of today isn't so much to kind of badmouth prescriptions in general, but really to educate. And that's what the whole purpose of this organization is. It's what the purpose of, in my opinion, functional medicine is to empower patients to understand their own physiology better so that they can kind of own their own health. And ultimately, when we're talking about these medications, we're not saying that they are useless. We're saying that they're useful if done and used appropriately and in the right setting, in the right context, and thoughtfully prescribed by someone who understands the nuances of why they're used and what they might cause from a nutritional standpoint in the body, a deficiency that would be. So disclaimer aside, statins. So statins are prescribed pretty commonly now for the main reason really is for cholesterol lowering. Ultimately, if you have cardiovascular disease, if you've had a stroke, you're going to get a statin. If your cholesterol, meaning the total cholesterol, is above 200, you might be prescribed a statin. If the LDL, or quote unquote bad cholesterol, is above 100, you might be prescribed a statin. And so it's kind of unfortunately become this if this then that type of prescription where it's almost like fast food or cookie cutter, where if those numbers come across, whether or not that patient has some other risk, they're given a statin or at least counseled on the use of one. And the issue I have with that is that they are great medications when they're used appropriately, but they have a laundry list of side effects. The way that they decrease cholesterol is really by decreasing liver synthesis of it. And ultimately, the body then removes circulating LDL cholesterol. But that was found when statins were first being developed as like a happy side effect of statins. Ultimately, the way that they protect the heart and brain is because of their anti-inflammatory properties. And cholesterol really, as we've discussed, is not the bad guy. I mean, it's been demonized. 80% of your brain is cholesterol. All of your cell membranes have cholesterol in them. It's the precursor to most of your hormones, including cortisol, including sex hormones. And it's just a really, really obviously important thing. And so lowering it is not always the right call. And so the side effects would be things like the ones that are commonly known would be like muscle aches and pains, almost to the extreme of something called rhabdomyolysis, where the muscles break down. It can really affect the body in a negative way, causing some kidney damage and potential hospitalization, pain in general, headaches. They can cause liver enzymes to become abnormal. So typically liver tests are monitored, at least in the beginning. From our standpoint, GI symptoms, abdominal pain, constipation, diarrhea, They can lead to things like impotence because of their effects on overall cholesterol filtering down to things like testosterone, mood swings. And, ultimately, if you precipitously drop cholesterol too low, which I see over and over and over again, we get this paradoxical uptick in risk where you now are giving something to decrease cardiovascular risk, and you may be increasing it because you took a cholesterol of 190 and dropped it to 120. You start to see cognitive decline and dementia when cholesterol gets too low. We see depression, we see bipolar, we see increased stroke risk when cholesterol gets too low. So, we've lived in this society of fearing fat for so long because we were misled. And you and I have talked about that ad nauseum. Fat, at least good fat, is not our enemy. It's absolutely our friend. It's what the body wants. And so segueing into the nutritional deficiencies that statins cause, it's fat basically, or at least fat soluble nutrients like CoQ10 is the most well known. And then the fat soluble vitamins, which are A, D, E, and K, as well as omega-3s. And so if you think about just that list alone, if you have any knowledge of what these nutrients do for the body, we are now impairing immune function. We're now impairing mitochondrial function. We're now impairing wound healing. We're now impairing energy and your Krebs cycle, how you're processing macronutrients, just by taking these few things away. And so I feel like when someone is prescribed one of these medications, they should be counseled about this. Bare minimum, they should be concurrently placed on CoQ10. Vitamin D should be measured on everybody. Everybody needs omega-3s. You can't eat enough salmon. Everybody just needs them. But I think that that's just a really glaring example of one of the problems with these prescriptions that are just kind of given out willy-nilly.
It just hit me because I grew up in the 80s and 90s. I call that the fat phobic, decade, if you will. And again, I was in the fitness industry. I was a fitness director back then. And so I was one of them, because that's what we were taught, low fat diets. Obviously I have done a complete 180 now. So you're telling us that the statin drug itself is minimizing the body's ability to have these types of nutrients such as CoQ10, AD, E, and K, fat soluble vitamins, as well as omega-3s. And at the same time, most likely these folks are probably told to go on a low fat diet, I'm assuming. So they're not even getting it in their diet. So the medication's dropping it and they're not getting it in their diet.
Correct. Okay. Yeah. And I mean, like there are other alternatives to statins that should be tried. And then, for instance, obviously lifestyle is really what we push forward, but that takes time. So clearly in the short term, depending on the numbers and the risk, you may have to intervene, and that intervention doesn't always have to be aggressive. Again, you have to get as much information as you can. And the problem concurrent to this is that, the typical cholesterol panel is cholesterol, total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. And then some ratios are calculated from that. And that's not the whole picture. Not all LDL cholesterol, which is the bad cholesterol, is actually bad. Some of it is big and fluffy and functions like HDL, sweeping through the blood vessels and cleaning them out. And not all HDL is good. Some of it is dysfunctional and causes problems. And so what we typically measure in our clinic is lipid fractionation, and you're actually looking at the particle number and the particle size to determine the functionality and whether or not these are the good cholesterols and the bad colesterols, or some combination, thereby changing the risk versus just looking at these kind of big picture numbers that may not convey as much risk as you thought. And then here's a statin that's causing all these problems that you may be causing more damage. And obviously our mantra is first do no harm. And so you can consider things like red yeast rice, which is a natural statin, does exactly what statins do, minus the side effects, minus the nutritional deficiencies, assuming they don't have a yeast overgrowth problem. You can give berberine, which is a phenomenal nutraceutical. B5, which is pantothenic acid in high doses, helps with lipids. High dose niacin, another B vitamin, B3. Plant sterols, fiber, which nobody eats enough of. These are all things that you can try in conjunction with teaching them about good versus bad fats. I grew up in the same generation. We call it the snack walls generation, right? Everything was like low fat, high carb,
Diet Coke.
No one talked about sugar. It was like, just eat as much as you want. Like, it's not bad. It's easily the worst thing for you. So, so that would be my advice on statins, would be twofold. One, make sure your practitioner is being mindful about prescribing it and considering alternatives and at least the nutrient deficiencies that can ensue. And two, if they're willing, and they should be, I don't know why they wouldn't be, get that expanded profile to really truly see what your cardiovascular and stroke risk is based on your lipids alone, because they're not as bad as you think.
You said expanded profile, and I know that you do different tests at your clinic. What kind of tests should the patients potentially be asking for?
So it's called lipid fractionation, or an NMR is the other name for it, depending on the lab. But LabCorp does it. I mean, this is not fancy stuff. LabCorp does it, Quest does it, BioReference does it. I mean, this is like every lab in the country has this. You just have to ask. And this is not like you need to see a functional practitioner. Your regular doctor can easily order these tests. So lipid fractionation, another test I like to check is something called apolipoprotein B. Which is a pretty bad player. And if that one's normal, again, conveying less risk, maybe you're not jumping to a statin. There's a genetic marker called LP little a, or lipoprotein A. I personally think the reason they don't test that one is because statins don't treat it. And if you get a cholesterol panel that shows you might need a statin and your LP little a is elevated, they have to consider something else. And then why would they give you a statin? It's almost like, don't ask, don't tell. I mean, literally, I have so many patients that come in on statins and their lipid panel might look okay, might look good on a statin, but then we check these other markers and those markers are abnormal, and which is proof positive that the statin is not doing anything for them. And I still have to do the functional stuff to get those numbers nice. And ultimately, we may then get their total cholesterol too low and have to peel back the statin, which is ultimately what they want anyway. So these are not super expensive tests. They're not super fancy tests. Every lab can do them. You just have to ask your practitioner. They might give you a song and a dance about how insurance won't cover it. You can easily justify it depending on the risk of the patient. I do it all day long.
Wow. We're going to have to talk offline, and I'm going to have to get some of this information out literally in content form too. That's huge.
Sure.
All right. I know there's a list. There's a list of meds we want to get to. You talk a lot about PPIs. I know. Tell us more about those.
Yeah, I have a personal hatred for this one. Sorry. So I was on one of these. I think that's really why I love doing this so much. Is, I mean, we can do another whole podcast about my personal journey if anybody ever even wanted to hear about it. But ultimately, one of my downfalls was being on a PPI for way too long, and I think so many people are on them unnecessarily, with no guidance as to when to stop and what it actually is doing to their bodies. I mean, they're over the counter, so you can just go and get it, and you don't necessarily need a doctor.
What is a PPI?
A PPI is a proton pump inhibitor. Okay. So things like omeprazole, or AKA Nexium, the purple pill. I'm not trying to throw Nexium under the bus. I mean, there's a gazillion of these things. They're all over the place. And they're acid reducers. And in the same vein, there's H2 blockers like Zantac and Pepcid, also known as ranitidine or famotidine. And so these classes, although they're separate, they're both meant to kind of suppress stomach acid in different ways and protect the stomach from excess acid if you have gastritis, peptic ulcer disease, esophagitis, gastroesophageal reflux disease. The H2 blockers are used for allergies. So really it's just for heartburn, essentially, right? Okay. So for me, these are just kind of these medications that are deemed to be so benign, and yet they're so the opposite. And here's why. So just as a side effect profile, they can cause things like headaches and GI symptoms. Again, I mean, all these things can cause nausea, vomiting, diarrhea. You can lead to things like opportunistic bacterial infections like C. diff, which is a really bad bacteria that overgrows in the gut, is refractory to traditional antibiotics, is now kind of refractory to what C. diff treatment was, and a lot of patients are requiring special medications. This is the only indication for fecal transplant is refractory C. diff. I mean, it's just a bad thing that hospitalizes a lot of patients. PPI set you up for that. I mean, that's just scary in and of itself. Yeah. The nutritional deficiencies that occur can lead to bone loss and therefore osteopenia, osteoporosis, and early fracture risk. And so we see our geriatric population that are already prone to this, that are placed on these heartburn medications without thought, and now they go get a bone scan and it's horrific, and they slip and they fall and they wind up with a hip fracture, and then they're hospitalized, surgery, and all these complications ensue that could have been avoided. A new study just came out that showed that they increased diabetes risk. They have been correlated with increased dementia risk. They've been correlated with increased risk of community-acquired pneumonia. So these are not benign medications, and all the ones that I just mentioned were all for PPIs, the proton pump inhibitors.
Yeah.
They deplete the body of magnesium, calcium, iron, B vitamins in particular, B9 and B12, vitamin D, and then most importantly, beyond the nutrient deficiencies, they suppress stomach acid, which sounds like a benign thing. In my world, it's like the worst thing. And by my world, I mean the functional medicine world. Like, stomach acid is there for a reason. Now, if you have too much, then figure out why and sort that problem out. Get to the root cause and sort that problem out. If you have too much and you need to quench it or quell it in order to be asymptomatic, do so while sorting that problem out. But don't just take an acid suppressor not thinking it's causing problems. You're decreasing your body's ability to activate intrinsic factor and absorb iron and B12. You're decreasing your body's first line of defense against bad bugs. That is the stomach. That's stomach acid. You're decreasing your ability to break down food appropriately so that when it does pass through the stomach into the small intestine, if you have gut dysfunction, which so many of us do, leaky gut or intestinal permeability, inflammation, that food that may not be a true sensitivity is now seen by the body as foreign because it's a larger macromolecule, and the body may react negatively and make antibodies or make immunoglobulins or lead to some sort of autoimmune response or an allergy, or something may ensue that leads to further things down the road. So it's not a benign thing. Ultimately, you need to figure out why you have these problems to begin with. And, is it IBS? Is it a food allergy or sensitivity? Is it small intestinal bacterial overgrowth? And then what can you do to fix the problem that isn't a PPI or an H2 blocker? Mm-hmm. Some of the things that we traditionally use would be deglycerized licorice root, zinc carnosine, aloe vera, marshmallow root extract. These are all benign things that work really, really well to kind of help the problem.
What about raw apple cider vinegar?
Sure. Perfect.
Okay.
Yeah. So these kind of weak acids that help the body stimulate acid production. Apple cider vinegar is also fermented, so you're getting some degree of probiotics that way, which can also be beneficial. We use Iberogast or traditional Swedish bitters to stimulate gastric acid production. Also helps with digestion, GI motility if the stomach is a little bit slow and it's emptying, which we call gastroparesis. But I mean, the stomach is just so important. And this is a really cool fact when I talk to patients about it. It's like this kind of aha moment where when we suppress stomach acid, we are changing the pH of the stomach. And ultimately, the pH of the stomach, which is supposed to be low, when the pH is low, that's acidic. Mm-hmm. When the pH is high, that's alkaline. Mm-hmm. So we're going from an acidic environment, low pH, which we want, to a more alkaline environment, a higher pH is what we don't want. Mm-hmm. The muscle at the top of the stomach, which is called the lower esophageal sphincter, closes in response to an acidic environment.
Gotcha.
If you decrease your stomach acid production and you're making that pH come up, it stays open. And so you get heartburn and you think, which makes common sense to me, if I have heartburn, I must have too much acid. Everybody thinks that, so I'm going to quench it. Paradoxically, you probably have hypochlorhydria or too little stomach acid. Right. And if you add some acid back under the care of a practitioner, you should never do this on your own, add some acid back in the form of betaine hydrochloric acid with pepsin, which comes in pill form, which we do in clinic, and then you quantify how much you need. You often find that it's transformative, and you get the pH low enough, the LES closes, they no longer have symptoms. Because as we get older, we make less and less stomach acid. So the presumption is always, I have too much, when in actuality, you probably have too little. And you need someone to kind of guide you through that. If you're on a PPI and you hear this podcast or see this podcast, please don't immediately go out and just stop taking it. You get this really bad paradoxical increase or rebound effect where you will make more stomach acid and cause more problems. You need someone to kind of guide you through a slow wean where you're taking a minimum dose daily while trying to stay asymptomatic, ultimately fold in an H2 blocker like Pepcid or Zantac, whichever one is not currently black boxed for whatever reason.
Okay.
And then you want to take the PPI every other day to every third day to every fifth day to get off of it. Then do the same with the H2 blocker. Now, not everybody needs that. I have some that go gung-ho cold turkey and they suffer for like a week and they're fine. That was the wean that I had to do because I was on a PPI for over 15 years because I didn't know any better at the time. And my doctors were telling me I needed it. I learned about functional medicine. I was able to figure out what my kryptonite in the diet was, remove the diet, clean up my lifestyle, get my gut right, and ultimately wean the PPI and put acid back. And to this day, I take stomach acid with my larger meals, and it was transformative for me. But it was hard, and it took a long time. I had dysbiosis, I had SIBO, I had nutritional deficiencies, and thankfully none of these other horrible complications.
You know, so folks are literally, you know, going to CVS or Walgreens, it's over the counter, and they've just kind of it's in their car. They just kind of live on them, I'm assuming. They're not even thinking the damage.
They do it. And the issue is, you know, even on the box, but clearly in small print, it says that you shouldn't take it for longer than 2 weeks, or if taken for longer than 2 weeks, consult your physician. Because the standard of care is you should be on a course for 2 weeks and then reevaluated. And if you need long-term use, you need to be followed clinically for these other problems in addition to nutritional deficiencies. And then why do you need it long-term use? The question is like, no one really asks why. We've lost the curiosity, you know, why do I need this medication? It's just, I need it. So I'm going to take it. It makes me feel better, moving on. That shouldn't be where we stop. And PPIs don't work the same way that an H2 blocker or taking Tums or Gaviscon might work, whereas to say you have heartburn, I take it and it gets better. They actually need a day or two, maybe longer, to kind of exert their effects. And so if you're taking one because you have heartburn and your heartburn gets better, that's probably a placebo effect, to be honest with you. Maybe it's helping to some degree, but honestly, that's not really how they work. They're suppressing the acid production by the parietal cells. They're not just quenching whatever fire is already there. They're not neutralizing it. Some sort of alkaline calcium carbonate, which is Tums or Gaviscon, something along those lines is necessary for that. But the short of the long is, you know, these are easily the more deadly over-the-counter ones as far as I'm concerned, along the lines of things like ibuprofen and Tylenol, which we're not going to probably touch on today. We can a little bit on the back end if you want, but you know, these are taken and the commercials that are on the TV like over and over again. And you think about when they're seen, it's like during the Super Bowl and during sporting events when like people are eating horrible food and the demographic is such where it's like, you know, probably a lot of like middle-aged men drinking beer, eating chicken wings who are currently experiencing heartburn. Go get your PPI, right? Yeah, wrong answer.
Yeah. And I mean, this is just typical Americans. And, you know, my understanding is, you know, we're the only country that has so many citizens on so many medications. And we need to pull back and look at why is it this way. Again, we're a cancer prevention organization, but when you start messing with the gut, the stomach, now we're seriously dealing with cancer and other diseases. And this is one
for sure. I mean, and then the nutrients too. I mean, think about some of the nutrients that are being pulled out. Like the one common one for both of these was D, right? Just vitamin D in and of itself. And if you're paying attention at all to this pandemic and what nutrients are important to prevent and or minimize complications related to COVID, it's vitamin D. Followed closely by zinc, which we're going to talk about with some of these others. And we are a society of low vitamin D to begin with. And then you're taking all these medications that lower it. It's just setting you up for immune deficiencies. And vitamin D isn't just about improving immune function, but it's cancer preventative. It's dementia preventative. It is cardiovascular risk reduction. It's hypertension treatment. It's improved thyroid function. It's treatment for leaky gut. I mean, oh yeah, and it does the whole thing with calcium and bones that everybody knows about, but that's like a silent second to all these other things. It is a steroid hormone that cannot be made more important than I mean, it's just too important. It's just too important.
And remind everybody what's the range? Like what's that bottom line, you know, for vitamin D?
60 to 80 is what we target. And so the measured range typically in any lab, and again, this is one of those tests your doctor should be doing at least once a year. I do it more frequently. I try to figure out when insurance companies how often they'll cover it. Like for instance, if a patient is low, and you're aggressively repleting, you can check it more often. If you overshoot and get a little toxic, you can check it more often. Typically, it's every 6 months, insurance will cover it. I think that's sufficient unless you're kind of getting crazy with your use of it. But you're not going to hurt yourself taking it. If you take gigantic doses for long periods of times, you're going to overshoot. But you need to get your levels up to like high 200s to experience maybe bone pain as a side effect. I personally have been in the 150s with no side effects patients as well. But over 100 is toxicity, below 30 is deficiency. Ultimately you need to be between 60 and 80 if you want to optimize it. And so that's our target in my clinic. And, especially this time of year, right? The days are about to get shorter and we see seasonal affective disorder. There's a study that just came out postulating that the reason that there's an uptick in flu, because there's flu in the summer, we just see it more in the winter. Why? One of the postulations in light of all the information that we're learning about D and COVID is that maybe it's because we see this seasonal variance in vitamin D levels in patients where their immune systems are less equipped to handle these viruses. And so there's a concurrent uptick in viruses in the winter months. And so if people maybe took more vitamin D because they're not getting it from sun or they're not eating it during the winter months, would we see decreased rates of colds and flu across the board during the winter? My answer is yes, of course we would. And seasonal affective disorder for sure.
And you've lived this. I mean, you've experienced this. You've experienced, a low level of D and some other issues and whatnot. And you've changed all this. So it's not like you went and got extra education in functional medicine because you are a medical doctor. You're an MD. You've actually lived this and experienced this.
My D was 16. My vitamin D level was 16 when I started my journey. No one was talking about it. No one was measuring it. And I was like, oh my God, that's bad. So, I was like, it's not funny, but I was like, do I have rickets? Like I had no idea, like it was that low. And ultimately I learned that I have some genetic SNPs or typos in the vitamin D receptor. So I can't really convert sunlight into vitamin D efficiently. And that's a very common thing that we see. People falsely assume that. I clearly wasn't eating enough vitamin D rich foods. And these are these fats that we've avoided. I had fat malabsorption in my gut. I was on some medications that were depleting it. So, it was this perfect storm. And ultimately now to this day, I take like 10 to 15,000 IU of vitamin D3, which is the active form, with K2, which improves or increases absorption and also keeps the calcium that's mobilized from being deposited into the blood vessels and more so deposited into bone where it belongs. And so, I found this nice happy medium for myself. And anytime I have even an inkling of I'm getting sick, I'll increase that to 25,000 or 50,000 IU a day for 3 to 5 days. And then I'll back off a little and just kind of go from there.
Yeah. We've talked a little bit about, in that podcast, it was vitamins, minerals, and metals, oh my. So if folks want to listen to that podcast, I know that you talked a whole lot more about vitamin D during that time together as well. We have so much more to get to. I wish we could stay on this conversation. All right, metformin. I know you want to talk about metformin.
Yeah, so metformin, also known as glucophage, is a diabetes medication. It's also used for this Western disease that's kind of been, we're just seeing it on the rise. It's called Metabolic Syndrome. Ultimately, when I was in medical school not so long ago, it wasn't even really a recognized diagnosis. This is something that, standard American diet, sedentary lifestyle, poorly controlled stress, poor sleep, all of these things, toxins in our environment, et cetera, have led to this metabolic syndrome where we have insulin resistance, we have high triglycerides, we have hypertension, we have low testosterone, we have this kind of spare tire around our midsection. So metformin is used for insulin resistance and diabetes and metabolic syndrome. It's used for PCOS and the metabolic derangements that go along with that. That's polycystic ovarian syndrome. These poor women that have these hormonal issues, which is an estrogen dominant condition, they go to their OBGYN and they're not counseled about how to become insulin sensitive and leptin sensitive. They're just like, here, take metformin. And I see these cases all the time, and I'm like mortified by it. There's a subset of individuals that take metformin for longevity, thinking that it helps with longevity because it does do some things with certain genetic pathways that can improve longevity, but at the same time, it is a direct toxic toxin or toxicant to the mitochondria. It depletes the body of B12 and B9. So we have this medicine that we're using for diabetes because it's insulin sensitizing. It decreases the liver's production of glucose. It decreases GI absorption of glucose. It makes the cells more sensitive to insulin. So it's working in that regard, but it's depleting the body of B12 and B9. It's a toxin to the mitochondria where we're making our energy from food. And it can lead to things like weakness and diarrhea and muscle aches and overcorrection of glucose and hypoglycemia, abdominal pain, nausea, vomiting, bloating, reflux, lactic acidosis, constipation. I mean, it's just, the list goes on and on and on. And then I find this always interesting. I think we talked about this. You know, you're diabetic, you get the diagnosis, maybe you're working on lifestyle, they put you on metformin. And one of the first common complications of diabetes, besides your sugar going up, due to the long-term dysregulation of blood glucose, is neuropathy, which is this kind of nerve problem, right? Diabetic neuropathy. And so maybe you're a diabetic, newly diagnosed, and you get on the metformin, and then your feet start to hurt, or you have numbness and tingling, and you go to your doctor, and they tell you, oh, you got diabetic neuropathy, and they start you on another medicine, like gabapentin, which is also called Neurontin, for diabetic neuropathy. Maybe that neuropathy is a B9 or B12 deficiency from the medication metformin that you're on, and it's not routinely tested. And now you've been given a medicine that caused a nutrient deficiency that led to a complication that's presumed to be secondary to the diabetes that you're given another medicine for. And that is that pharmaceutical loop that we often find ourselves in. And it's just mortifying. So, you know, these things should be checked by practitioners. Sometimes they are, sometimes they're not. When we talk about B9 and B12, it goes a step beyond just being B vitamins. These are the two that are at the center of this kind of methylation cascade. We can do a whole podcast about methylation. I mean, the short version is this: trillions of times a second in every cell in the body's undergoing methylation, which is our kind of internal light switch. We're turning things on, we're turning things off. It's add a methyl group, subtract a methyl group. It's a carbon and 3 hydrogens. It's ultimately how we're activating enzymes and genes and turning things on and off. B9 has to be activated to methyl B9 or methylfolate. B12 has to be activated to methyl B12 or methylcobalamin. And those two are at the center of this kind of wheel, this cog that affects all these, that affects neurotransmitter production and nitric oxide production and cancer prevention and dementia risk and IBS. And so if you're depleting these water-soluble vitamins that get depleted when you're stressed, and we're all stressed, that get depleted when you have adrenal issues or gut issues, and then you're taking a medicine that depletes them further, you're setting yourself up for things like cancer or dementia or IBS or mood disorders or poor methylation, which is affecting all of these. And we see methylation issues all the time, secondary to genetics alone. And now you are making those genetics more effective. You know, we've talked about genes loading the gun and environment pulling the trigger. You're pulling the trigger when you're doing this. You know, the genes are there. Doesn't mean that you can't leapfrog over them. Doesn't mean that you have to activate them. Doesn't mean that you can't dance around them. There's ways to do that. I mean, that's what epigenetics is. It's understanding the system as a whole and hacking it best you can.
Yep, exactly. And we understand that cancer truly is a metabolic disease. And so and we know that diabetes is a precursor to cancer. We don't talk about that a lot. Now, I think you know Dr. Melissa Hurt. She's a board member. She talks a lot about how cancer is truly a metabolic disease, and that those folks with, who are diabetic truly need to be, we need to reach them with our education, with some of the information that we have. And then in regards to methylation, she talks a lot about that too. I think I've even heard you all have these conversations before. And I love being a fly on a wall when you and Dr. Hurt are speaking, because we can have methylation issues. Not all of us are able to create what we need to create in our body. And again, what tests, like, how do you find this out? Like, what are you asking your doctor to do?
Sure. So she's great, by the way. We both love her. She's had her own journey, which will bring you to tears. And she's just an amazing person who has gone through it and understands it, and therefore has this relationship with her patients that it's just, I mean, again, like anybody who's been under her care is blessed to be so. But yeah, so the classic hemoglobin A1C is the downstream marker. We talk about downstream and upstream, so this is a good segue for that. I mean, downstream is essentially downstream. Here's your disease label and here's your prescriptive Band-Aid. Upstream is, how did we get here? What else is involved, factoring in genetics and environment and nutrition and hormones, and see the body as a whole. What can we do upstream to affect this and prevent it from happening? So we screen with a hemoglobin A1C. Are you normal? Are you pre-diabetic? Are you diabetic? Pre-diabetic is 5.7 to 6.4, above which is diabetes, below which is quote unquote normal. Optimal should be, you should aim for 5 or below. That being said, that is downstream and not always related to glucose. You need to be looking at a fasting insulin. You need to be looking at a fasting leptin or adiponectin. Adiponectin and leptin and ghrelin are these hormones that are upstream of all this that affect satiety. Am I full? Am I not full? Okay. They go to the hypothalamus, they go to the brain, and they say, you're full, stop eating, or you're not full, keep eating. Okay. And they will have a downstream effect on insulin resistance or sensitivity, which will have a downstream effect on your fasting glucose being elevated or normal, which then will affect whether or not you are the diabetic. And ultimately, do you need these medications and these lifestyle changes? So if you're looking at someone who has a normal A1C and you're patting them on the back, but their fasting insulin is 20, they're insulin resistant and you need to do something now before their A1C goes up. Okay. But if you're not checking that, you don't know that because the A1C is normal.
Gotcha.
Conversely, you can have an A1C that's in the pre-diabetic window and have a normal or even optimal fasting insulin. And I want to repeat that because it doesn't make a lot of sense.
Right,
you can have an A1C in the pre-diabetic window, but have a normal or optimal fasting insulin showing insulin sensitivity, but you're pre-diabetic. How's that happen? Because of chronic inflammation or toxins or nutrient deficiencies. It's not just an issue of blood glucose that we think it is. It's beyond that. If you're not factoring those other things in, you are missing the point. And so you have to measure these upstream markers to see what else is going on, because you might miss something important in that patient's history or in their lab work. If you look at the whole loop, you can kind of see the disconnect. And so you'll work on lifestyle, which is always going to be weight reduction and dietary changes, not just, counting calories, but rather finding what's right for you, what works best for you, what is your kryptonite, what gasoline are you pouring on the fire, what are the most inflammatory foods, what are your food sensitivities and allergies, what are the right ratios of fats and proteins and carbohydrates, and then ultimately using things like alpha lipoic acid or cinnamon or berberine or chromium. Berberine is great. Berberine is this incredible botanical. It comes from like Oregon grapefruit and golden seal that you can use it as an antibacterial and antifungal for gut stuff. It helps with insulin and leptin sensitization. It helps with lipids. Everybody should be on berberine. It's just amazing. Mm-hmm. So that's what we tend to do for our borderline diabetic or diabetic patients, is kind of look at the whole picture and see what else is going on. And when I talk to them about their risk, we don't break out cardiac and metabolic. We call it cardiometabolic for a reason. Okay. And you're right in what you said. Cancer loves sugar. It loves it, and it just like thrives on that. And at the root of all of these chronic problems is inflammation. Mm-hmm. And if you can figure out where the inflammation is coming from and stomp it out, then you're solving so many downstream problems. You really, truly are.
Yeah. And that's one of the things that we do with our Healing Belly basket that we give to cancer patients and survivors. It's anti-inflammatory nutrients. We don't follow a certain diet plan or whatnot because everyone is different. And so, but we believe in high quality fats, high quality proteins, green up as much as possible. Mm-hmm. Of course, fiber, hydration, extremely important. Most people are dehydrated, but we always talk about the nutrients that actually bring down inflammation in the body. I think that's so important because you can find them anywhere. You can just don't skip over them at the grocery store. You don't have to go to some fancy schmancy, grocery store unless you want to, which is fine, but you can find them anywhere.
Yeah, they're everywhere. You're talking about things like coconut oil, and you're talking about things like avocados and fish oil and, all the
herbs, garlic and red onion and all the herbs, parsley, rosemary, all the basic.
Cilantro and dark leafy green vegetables and crucifers, which are broccoli and cauliflower. These are not these like crazy esoteric things that you have to have $1 million in order to get, and they're only found at one place. You can get these anywhere. Granted, the quality might vary, but you can get them, and you don't have to break the bank. You could figure out ways to get these nutrients in your system that works right for your budget, that works right for your family's tastes, likes and dislikes, sensitivities and allergies. And if you need education there, I mean, that's the whole point of all this, is to try to, for us to educate you on what's important, what to ask your provider, what tests should be done, what should you be considering, what you should be reading about. You know, I feel so horrible for so many of my patients that show up and they start crying when we have our first new intake, because they feel validated for the first time. They feel jaded towards healthcare because they feel like they haven't been heard. Yeah. And I'm actually listening to them, and they're like overwhelmed. Like they looked up something online and they bring that to the table, and I don't dismiss it or tell them that they're crazy. And they're like, oh my God, I played Dr. Google and this guy's not yelling at me. You know, this guy's not like, you know, waving his MD in front of me. Like, how dare you do your own research about your own health? Like, it's just insane to me that anybody would do that to someone who's just trying to be proactive about their own health. Like, the whole point is for you to educate yourself so that as a whole, we can be a healthier society, and start to change the trends that we've seen, which are horrific, which every chronic disease state on the rise, despite genes not changing for thousands of years, our children having a shorter lifespan than we do for the first time in the history of humankind. That is unacceptable to me.
I 100% agree. And this is one reason why I am happy that we're doing this podcast, and I'm already taking notes about the next one. To wrap this up, because we're coming into about 45 minutes, I do want to talk about steroids, and I'm going to put antibiotics and pain relievers on the back burner for next time. But I think it's important to talk about steroids because our president had COVID and he touted steroids. I got steroids. I know that steroids are given to folks in regards to COVID. I've been on steroids before for certain reasons for a brief moment in time. I felt great. Yeah. I felt like I was 20 again. I could run forever. Gotta love the steroids. Help us. What's steroids?
I have a similar love-hate relationship with steroids. I'm a pretty allergic individual. And I have unfortunately been through anaphylactic shock a few times because of tree nuts. And so I've had my share of prednisone, and I feel like I can conquer the world on steroids. Yeah, too bad it's so bad for you. And then before we go into steroids, just a long line of painkillers and antibiotics, antihypertensives added to the list for the next podcast. Things like diuretics and ACE inhibitors and calcium channel blockers, beta blockers, etc. Those need to be talked about as well. But yeah, so steroids, we're talking about things like prednisone, Solumedrol, Decadron is the one that they're using a lot in COVID. And yes, absolutely, they are life-saving and transformative. I know that firsthand when I couldn't breathe and my blood pressure was dropping, and along with some epinephrine, the steroid saved my life. That being said, chronically, you do not want to be on these. Repetitively, you don't want to be on these because they lead to issues with bone loss. They lead to issues with leaky gut and gut dysfunction. They lead to immune suppression. They lead to immune dysregulation. They lead to nutrient deficiencies. And those would be things like, again, vitamin D, vitamin C, calcium, magnesium, potassium, zinc, selenium. This is the magic list. I mean, think about that list. We talked about D. Everybody knows vitamin C is important for your immune system. We don't get enough of it. And when you're stressed, you churn through it. Who's not stressed nowadays? Vitamin C is super duper important. COVID patients that are hospitalized are getting IV vitamin C for a reason. When has modern medicine ever embraced IV nutrition ever before now? In addition, zinc. I mean, zinc is now being pushed out there as how important it is. And all the zinc ionophores, which are basically these things that help chaperone zinc into the cell to make it work more effectively. That's basically what azithromycin and hydroxychloroquine do. That's why they were effective, not because they inherently fight COVID, but because they chaperone zinc, a mineral, into the cell where it has immune benefit properties, where it's antiviral and it decreases the viral shedding that occurs and the ability of the virus to kind of get into the cell to begin with through those ACE receptors. Zinc and selenium are important for thyroid function. Potassium is important for blood pressure, important for cardiovascular risk reduction. Magnesium, you and I, our friendship was developed over magnesium conversations, right?
It was.
So calcium and magnesium for obvious reasons. So steroids, they lead to peptic ulcer disease. And then all of a sudden what happens, you're put on a PPI, which we just talked about.
Right.
Steroids lead to leaky gut, which leads to dysbiosis and bacterial and yeast overgrowth, potentially SIBO, which jacks your immune system up, right? And then down the road, you have inflammation and ultimately maybe the C word, unfortunately.
Yeah.
They lead to bone loss, osteopenia, and osteoporosis. They can lead to steroid-induced psychosis. They can lead to adrenal suppression and ultimate exhaustion. They can lead to diabetes. And so therefore we have the inflammation and the dysglycemia again, because steroids are corticosteroids. We make them in our adrenals. Glucocorticoids, that's what cortisol is. That's what the stress hormone cortisol is. It's a glucocorticoid. That's why you feel great when you take them. So they have those anti-inflammatory. If you have autoimmunity, they make you feel great. If you have allergies, they make you feel great. But then what, right? You're still not addressing the underlying issue. Ultimately, they wear off, or you have to wean them because of a complication. And then you have these issues to address with still plus or minus some that you might have created. And so that's the big issue for steroids. I mean, I wish they didn't cause a problem because I would be on prednisone every single day. I feel like a champ on it, but please don't go out and try to get prednisone.
No, I know. This has been extremely impactful. I had no idea that we were going to be able to cover this much in about 45 minutes.
Yeah, talk fast.
Oh, and it's good. And it's good. I'm glad that we recorded it because I'm going to have to review it over and over again. This is extremely important. And I want to continue this conversation, and we'll add the beta blockers, the diuretics, ACE inhibitors,
calcium channel blockers, ARBs, which are kind of along the same line of the ACE inhibitors. It's just basically antihypertensives, antibiotics. And then pain meds would be, I guess, the over-the-counter ones, the NSAIDs and Tylenol, and we could talk about opiates too. I mean, whatever you want to talk about. I mean, I'm birth control. You know, we can talk about oral contraception with regards to what it does. I mean, ultimately, all these things are going to lead to some degree of bodily dysfunction. Any medication will. It doesn't mean that you don't need it. It doesn't mean that you shouldn't take it if your doctor prescribes it thoughtfully and counsels you about what it can do, and you educate yourself. And if you can't find an alternative that's natural, then take it, because it might make you feel better. But work with someone who's willing to consider that and who will hold your hand through your health journey and not slap your hand and not scold you, and ultimately kind of teach you about you. I tell my patients all the time, my goal is to have you see you through my eyes. And if I've done that, then I've done my job. When you don't need me, I've done my job.
Right. You said something though that I thought was really important. And that was, if it makes you feel better and you're being monitored, you know, then, you know, take it, but be monitored and know what you're getting into.
Yeah.
You didn't say if it treats you, if it fixes your problem.
Right.
I think that's the main part of this whole discussion here, is that these are Band-Aids, you know, these are Band-Aids. This is not your cure, you know, and I think more and more people are being Dr. Google and trying to find out, okay, I'm tired of paying for this. I'm tired of feeling all the side effects. I'm tired of relying on a certain pill or pills every day. And they're looking for information. And so, this is why this is so important, not only because a lot of these medications can set you up for nutrient deficiencies, which can lead to diseases like cancer, but at the same time, people are they're wanting this information. And I have experienced personally, sometimes we feel like we get our hand slapped if we ask questions to our medical provider.
And that's shameful. That's the system that we have right now, and it's been broken for too long. And that's a shameful way for providers to act. And I apologize on behalf of other doctors and providers all the time to my patients, and I shouldn't have to, but I do, because they need to hear that, because they're not going to get it from them. So I might as well do it. At least they'll feel better. But you're right. This doesn't, you know, when you take an antihypertensive, your blood pressure might look nicer, but it's not making the underlying reason for hypertension go away. It's just treating the numbers, and you might feel bad, but the numbers look nice. And you go to your doctor and it's 120/70 and they're patting themselves on the back, but you have impotence. Like, that's not a good thing, right? You don't feel so awesome, but your blood pressure's better. Like, you have to consider all these things. We're too fixated on disease. We're too fixated on labeling. We're too fixated on prescriptions and curing. We need to be promoting wellness, and that's not just physiologic, physical wellness, but it's mental and spiritual wellness. It's sleep, it's exercise, it's diet, it's all these things. It's social interconnectedness. So much of that has been lost in medicine through this pharmaceutical shuffle and this fast food turnstile of medicine that we've created, and it needs to be changed.
Yeah. Thank you so much, Dr.
You're
Jenski.
welcome. Yeah.
Very important. For those of you who are listening, you're welcome to contact info@hcb2.org for more information. But Dr. Jenski, where can people find you?
I actually have a practice called Richmond Integrative and Functional Medicine, along with Dr. Aaron Hartman. We are in Midlothian, and we have a website. You can just Google RVA Integrative. There's great information on there. There's access to diet information, there's blogs, there's links to books to read and articles. I mean, again, we're about empowering patients. And then anytime you want to do a podcast, they can find me there, because I love doing these with you. It's always a pleasure. We have a couple other ones on the site, and yeah, that's about it. You know, I'm just keeping busy, seeing as many people as I can.
Cool. Awesome. You can find the Fight Right podcast. It's Hitting Cancer Below the Belt's Fight Right podcast on iTunes, Spotify, and also on our website. And I'll also be pushing this out via social media. So thank you again. And you will see Dr. Jenski again, everyone. And continue to fight right. Take care, everyone. Bye-bye.